Hi everyone, my name's Helen Alexander. I'm a research fellow from St John's in London, and I'll be speaking about the skin microbiome in atopic dermatitis. I'd like to thank very much the organisers of this symposium for inviting me to speak today. So to start with, the healthy skin microbiome. Firstly, the methods that we use to detect the skin microbiome have really advanced over the last 10 to 20 years. Previously, the only way that we could look at this was through trying to grow bacteria in the laboratory. And in the case of Staph aureus, for example, shown here, this is quite straightforward, but for the vast majority of microorganisms living on the skin, this is impossible, and these were previously undetectable. Whereas now we can extract and sequence the DNA from the microorganisms living on our skin, align these sequences to reference databases, and this allows us to quantify the proportion of species in our skin communities. And we can compare this, for example, in patients and controls. And we can also look at the abundance of microbial genes, which gives insights into the potential function of the skin microbiome. So the skin provides a very diverse ecological environment for a wide range of microorganisms. We know that skin site is important, and sites rich in sebum, such as the forehead and the upper chest, harbour more lipophilic bacteria, compared with dry skin sites such as the forearm, which has a more diverse microbiome. In contrast again with more moist sites such as the popliteal fossa, which harbour more staphylococci. In addition, we know that the skin microbiome changes with age. And for example, here showing advancing stages of puberty, the skin microbiome changes quite significantly. And this reflects the hormonally induced changes in sebum concentration on the skin, which favor the growth of lipophilic bacteria. So moving on to the AD skin microbiome. So we know that Staph aureus is a very important species in atopic dermatitis, and it's the most common organism to cause infection in the disease. It's been known for a long time that most AD subjects are colonized by Staph aureus, compared with only 5% of healthy individuals. And we know that antimicrobial treatments are very important in AD and one of the most commonly prescribed treatments in the disease. And a number of studies have shown that these antimicrobial treatments offer additional benefit even in individuals who don't have overtly clinically infected AD. However, other studies have not shown this, and a Cochrane review published in 2010 failed to find any evidence that commonly used anti-staphylococcal interventions are helpful in people with eczema that's not clinically infected. So the question still remains of what is the role of Staph aureus in atopic dermatitis? Is it really causative in the pathogenesis of disease? Does it just exacerbate pre-existent AD, or is it simply a bystander of the impaired skin barrier and inflamed skin environment? So skin microbiome studies have helped move us forward towards answering this question. Staph aureus has been shown to increase in AD and increase during flares of disease, and its relative abundance correlates with disease severity. And this study also showed that it's usually a single strain of Staph aureus that increases during a disease flare. And we know that there's over 200 different Staph aureus strains with quite wide variability in their genomes and functions. And so it may be that it is strain-specific features of Staph aureus that's important in atopic dermatitis. These studies have also shown that the overall microbial diversity is reduced in atopic dermatitis, as shown here by the orange boxes across different skin sites, and that the diversity inversely correlates with disease severity. And we know that commensal species, such as coagulase-negative staphylococci, such as Staph epidermidis, may aid skin homeostasis and protect against the pathogenic effects of Staph aureus. And other species, such as Cutibacterium acnes and the gram-negative Roseomonas mucosa, have also been shown to inhibit growth of Staph aureus. And it's likely that the early life skin microbiome may be important in atopic dermatitis. So there have been some studies that have shown alterations in the early life skin microbiome in individuals who then go on to develop atopic dermatitis. So in this study, shown here, the staph abundances at month 2 shows differences in those individuals who went on to be affected by atopic dermatitis at month 12 compared to those that were unaffected at month 12. And the abundance of Staph epidermidis was significantly reduced in those who went on to be affected by AD compared to those who weren't, suggesting that maybe Staph epi is protective towards the future development of atopic dermatitis. So to summarize our understanding of the skin microbiome in AD, we know that there's enhanced Staph aureus colonization in the disease, and this is likely to be due to a number of factors, such as the major disruption in epidermal skin barrier, the overall reduction in microbial diversity, and reduction in antimicrobial peptides. In addition, Staph aureus itself has a number of virulence mechanisms which are likely to drive inflammation in the disease, for example, through production of enterotoxins, delta toxin, and alpha toxin, each of which activates different components of the cutaneous immune system. And in addition, the cutaneous commensal microbiome is altered in atopic dermatitis, and this is likely to have impacts through changes in competition for resources, changes in the pH, which affects, for example, Staph aureus colonization and growth, as well as through production of factors such as phenol-soluble modulins and antibiotics. But we don't fully understand how each of these factors is important in atopic dermatitis and how it works together in the disease. So moving on to the virome and the microbiome in atopic dermatitis, or the fungal microbiome. So there's very little data on this in AD, but this study, for example, did show that Staph aureus alpha toxin may modulate the skin susceptibility to viral infection in vitro. So in the presence of Staph aureus alpha toxin, the viral load of HSV was significantly greater in keratinocytes, suggesting that in AD, potentially co-infection with Staph aureus and will facilitate the susceptibility of the skin to HSV, as in the case of eczema hepaticum shown by these photographs here. In terms of the fungal microbiome, we know that in healthy skin, adults have a reduced diversity of fungal species compared with children, but we need more studies looking at this in atopic dermatitis. And as we have people from all over the world at this conference, I'll now speak a bit about geography, ethnicity, and the skin microbiome. So there have been a few studies comparing the skin microbiome of individuals with healthy skin across different countries and different geographical regions. So this study, for example, showed differences in the healthy skin microbiome from individuals from the United States compared with Tanzania. And here, comparing individuals from different parts of the United States, as well as individuals from South America, showing that individuals clustered based on their geographical region. And this raises the question of whether geographical or racial differences in the AD skin microbiome underlies the different clinical phenotypes that we see in atopic dermatitis from individuals with different skin types. So, for example, individuals with dark skin with atopic dermatitis have more violaceous erythema, may have more extensor as opposed to flexural disease, and the disease may have a more follicular pattern. And we need studies looking at the skin microbiome in these different skin types to see whether there are differences, whether these individuals have a different microbiome signature, and whether these differences are linked to differences in phenotype. This study compared differences in Staph aureus strains in AD subjects from different racial groups from the United States, and showed that there were different Staph aureus strains across these different groups, and these different strains had different profiles of superantigen genes, which have been shown to be important in atopic dermatitis. So finally, moving on to some examples of how the skin microbiome may be harnessed to treat atopic dermatitis. So firstly, this study used an autologous skin microbiome transplant in mice and then in adults with atopic dermatitis, and in both cases showed that the abundance of Staph aureus was significantly reduced after treatment with commensal staphylococci in the form of topical microbiome transplant. And in this study, a gram-negative species, Roseomonas mucosa, was used in a clinical trial to treat both adults and children with atopic dermatitis. And you can see from the clinical photographs after 10 weeks, clinical improvement, also measured by objective severity scores and a reduced need for topical steroids. And this is the data in children. So to summarize, hopefully I've shown that the skin microbiome is significantly altered in atopic dermatitis, particularly with increased Staph aureus and reduced commensal diversity. The early life skin microbiome may be important in disease development. There are different geographic regions and ethnic skin groups may harbor distinct microbiome signatures, and further research is needed to understand these differences and how the microbiome interacts with the cutaneous immune system to mediate disease. And finally, I've shown some exciting examples of early novel microbiome-based therapies for atopic dermatitis. Thank you very much for listening.